We're going to go ahead and begin. There are some people who are using interpretation. Be sure, go ahead and use the icon. If you can hear me, it's because you're all set up for interpretation to English. I am Jody Grawl. I'm leading the working group, and I will be providing interpretation.
Once again, dar las gracias a Jody Grohl, el líder del grupo de trabajo de la.
I would like to thank Jody. I will be interpreting from Spanish to English. I'd like to ask everyone once again, please turn off your microphone so that we don't have distractions for the panelists. We have decided to use this open meeting mode instead of webinar.
If you can help me mute a few people, that'll be great.
We may need some help to mute a few people. Please mute yourselves. We are hoping that at the end we can open up our cameras and open up our microphones to have more open discussion. I have the pleasure as head medical chief of Operation Smile and president of the Permanent Council of the G4 to be your moderator. Also recognizing Jody as the coordinator of the working group. Welcome also to all of you. Thank you for your time to be here today. In the recent months, the Latin American and Caribbean Working Group of the G4 has been organizing these informative sessions. And we've been talking about the lack of access to surgical care. And we've been trying to organize platforms, increasing platforms in our region to serve patients in need of surgery and to have more connections between our organizations. Today, we're going to talk about the topic, safe surgery during the pandemic, emerging protocols in Latin America and the Caribbean. We have a panel of health professionals who represent members of the G4 Alliance. We would like to thank them. All of them work very closely with G4 Alliance members, such as Mobile Surgery International, Operation Smile, Smile Train, and others.
Dana, if you can detect that microphone, I appreciate it.
Please close your microphones. Today we'll be talking about what all of these practitioners have had to do to resume surgery amid the pandemic. We have RN Tatiana Morales, who works as the Executive Director of Operation Smile in Nicaragua. And she fulfills several roles for Operation Smile in Nicaragua. Welcome, Licenciada Morales. Thank you for being here. We also have Dr. Lourdes Santiso, plastic surgeon who studied in Brazil. She is the plastic surgeon chief at the Roosevelt Hospital in Guatemala and general coordinator of the children's burn unit at this hospital. She's also a founding member of Burn Children Foundation in Guatemala, and she works closely with Physicians for Peace in Guatemala. We also are very happy to warmly welcome Paula Andrea Gómez, very experienced anesthesiologist in cardiovascular surgery and other areas in Colombia. Has a very prominent career in Colombia. She's also
trabaja en el Hospital La Samaritana y la Clínica Neiva y funge también como miembro del Consejo Asesor Médico.
Also a member of the Medical Advisory Board of Smile Train in South America, in addition to her many varied credentials. Also, Dr. Nicolas Sierra, he craniofacial surgeon with the Barcelona Hospital, Valle d'Hebron, medical director of Mobile Surgery International, and chief of surgery for their current mobile unit in Oaxaca. Has also worked together with Smile Train. This mobile unit is doing craniofacial surgery together with Smile Train. Welcome, Dr. Sierra. Also, welcome Dr. Percy Rossell, plastic surgeon from Lima, Peru. More than 20 years working in the specialty. Long list of credentials. And so credentials from Harvard and UCLA, and member of the territorial committee. He's currently scientific director of the Medical Advisory Board for Smile Train in South America. Welcome, Dr. Rossell. Also, Dr. Emanuel Thompson, anesthesiologist, working in the Rafael Hernandez Hospital in Panama. And since 1992, affiliated with Operation Smile. And he is now the regional medical official for Central America, Mexico, and the Caribbean. Welcome.
Entremos en la materia.
Let's get right into our discussion. I'd like to remember again, the idea is to have a discussion among this diverse group of professionals and later to open up to a broader discussion. So I'd like to begin with the panelists with a very specific topic. The pandemic has changed the world in countries throughout the world. For each of you, what has been your most difficult professional experiences during these last 12 months around COVID?
De la opción, quizás empezamos, ¿qué les parece con la licenciada?
We could begin with with Nurse Morales.
Bueno, realmente cuando escucho esta pregunta me impacta.
When I hear this question, it makes me think about a year ago when the whole topic began of the pandemic. It's been so difficult for every country. If it was difficult for highly developed countries, if you compare that with Latin American countries, there were very difficult moments, very complicated moments in our country. When it began, there are many people who started to get information from wherever they could. And many of the companies started to raise their prices for the materials we used. So many hospitals did not have the PPE protection material they needed. That was a huge impact for us. We weren't expecting, in the middle of a pandemic, the basic supplies we needed, the basic facial, just a surgical mask would all of a sudden cost $10. So there were different, very difficult moments.
No solamente de los equipos de protección que tuvimos en el país, creo que no solo Nicaragua pasó este momento.
It wasn't just Nicaragua that suffered this lack of PPE or the very expensive cost of it. We also saw a very strong crisis among the population. Some people didn't have access to information, and some people seemed to get too much information. People seem to suddenly believe, I need to get this medication, this is going to work. So for Operation Smile in Nicaragua, when the first positive case was announced in Nicaragua, we were in the middle of a surgical campaign. We had 80 patients. And suddenly we heard there was the first positive case. We thought that this was not only impacting our mission, this was a crisis for the safety of our patients and for our team. It was indeed a moment of shock for our healthcare professionals. And it was so difficult for us to protect ourselves without access to basic PPE. I'd like to invite Dr. Thompson if he has any additional comments. Good afternoon, everyone. I think Tatiana has expressed the feeling that of impotence, of insecurity, of uncertainty. That was what most impacted all of us. I could say the majority of the countries in the world, like Tatiana said, just to see the evolution of this pandemic, this health crisis, to watch how it unfolded in the wealthy countries, and to imagine our uncertainty here in Latin America, to see if that's how bad things are there, and they have health systems with more resources, what is going to happen for the Latin American countries? We tried to do everything we could to keep moving forward for our health systems. And in our organizations that provide assistance for patients, we were working together with the public institutions. For me, it was very important to know if the public health systems collapsed, what was going to happen with us, with our patients, with our work. For our patients who have cleft lip and palate, what was going to happen to them? Once again, we're talking about the uncertainty at the beginning of the pandemic. Dr. Rossell, would you like to add something? I think I agree with my colleagues. When we heard about what was coming, and knowing that we were not prepared, I think we were all certain that we were not prepared. And that was so difficult to know that we were going to be facing this in very bad conditions. And all the elective treatments that our patients needed were going to be set aside because of this health priority. Over time, we found some solutions. We've looked for and found some solutions to keep working. And we're finding different ways of solutions. Once again, as professionals, we are committed to keep moving forward. Does anyone, Dr. Paula, do you have a comment? Or Dr. Sierra? Yes, I agree completely with the other panelists. I think the most difficult moment for our organization in Oaxaca, in Mexico, had to do with the uncertainty around the decision-making of resuming surgeries. We weren't very clear about what were the conditions that would be needed to be able to operate safely. What were the indispensable characteristics? There weren't very clear guidelines. And we are not in a context we don't have very good decision makers or clear guidelines. We looked for the World Health Organization, looking for guidelines, and different European and North American guidelines, but it was very difficult to land on protocols for us. And in the same way, we were seeking clinical practice protocols. A lot of academic organizations were putting together different solutions, Operation Smile, Smile Train. In the end, I think the most difficult thing was I, as a medical director, have to make decisions. And I have to assume the responsibilities. The responsibility for the health of our professional staff and our patients. Without a lot of clear knowledge, without a lot of academic research to fall back on. There wasn't clear academic clarity. That was the most difficult thing. It's a huge responsibility. Dr. Gómez, would you like to add something? Good afternoon. I arrived, I'm sorry, a little late, but I got here. Regarding what you're talking about, for us in our countries, when we were seeing what was happening on the other side of the world with this pandemic that no one had seen before, we were looking very closely at the strategies that were happening in our country, in Latin America. We were some of the first to reopen our ORs, especially in my specialties in cancer and cardiovascular surgery, because we were going to patients were going to start to die not from COVID, but from these other diseases. So together with the surgical teams, we began to work to be able to find a way to surgically manage safely. Always thinking about the safety for the patient. And then with that first wave of COVID, but there are illnesses that can't wait, like the ones I treat. And when we are looking at the right to health as a right, would we be further risking the health of the most vulnerable patients if we don't do surgery? In our country, many missions are still halted because of fear or because there are not clear protocols. We don't know what is going to happen with this pandemic. We don't know what the consequences long-term for patients who are positive with COVID. We don't know what the consequences will be. It's going to take a while for us to know. A lot we won't know until time. This is a really important point. To summarize a little the sense that I'm hearing from all of you, as health professionals, we always prioritize the safety of our patients. And that takes us to have to develop protocols to care for our patients. Talking about the impact on the patients of the suspension of work. What are the most difficult things you've seen as health professionals in your fields with your patients? in this pandemic. At the beginning, it was
lo recibimos, por supuesto, con una alegría, yo creo que enorme.
Fortunately now, many of us doctors in the region are starting to get vaccinated. We're very happy to get it. We know that our care, we have to assume our role, our medical role, sometimes even risking our own lives. This is the war that it's our turn to face, and we are the most prepared to manage it. I think what is still an area of uncertainty and giving us fear, we still don't always know how to find the positive patients. We don't know in the pediatric population how to know who is positive. It's very impressive. Yes. Tatiana, what is the panorama in Nicaragua? Specifically speaking of the needs of the patients? Of course, yes. For our patients, there's been a really big impact. When we talk about COVID, we were in the middle of a work campaign. And when I hear the doctor talk about the right to health, it's so complicated to reach the patients and to tell them, or to tell a mother, and she maybe was waiting months or years for a surgery. It's very difficult to tell her, we're not going to operate on your child because of COVID. For us to take that information about the COVID to a mom, she doesn't want to hear about COVID. They maybe come from very remote regions that are, maybe they're not informed about what is a pandemic. Maybe they don't have any information what the protection measures are. It might be a mom who for months, for a year, has been completely focused on what do I have to do to save the life of my child. So they have been waiting. Their child can't eat well, or is too big and needs to get the surgery urgently. So I have to measure, as our organization, we have to take into account not only the surgical topic, but also think about, we have our whole multi-specialty team. Maybe my surgeon can't operate, but I have to engage my psychiatrist to speak with the family. Among the patients, it is always a big impact. And then we're always having more and more on the waiting list. We're always going to have a waiting list. We always have people waiting to get surgery. But we as organizations, that's what we exist, to help people, to bring that benefit, those who most need our help. And so for us to be in a position to have to say we have to stop, Dr. Rossell, Peru has been one of the countries hit very hard by COVID. How has it affected? How do you tell a patient whose elective surgery is canceled when they're seeking your help? How do you explain to them? Here, our mortality rate per capita at one moment of the pandemic has been very, very high. The hardest, the most difficult part of this situation, children they're not aware of what's happening in the pandemic, that the families don't understand. For them, the priority is to have the surgery they need. we have to be very honest, very truthful in our relationship and in our communication with them. We have to explain to them, we have to do this surgery in the best conditions possible. We may have to wait. Being honest and transparent with our patients, that was working. But that's the most difficult part. The parents, they're carrying this heavy burden. Dr. Sierra, in Oaxaca, Mexico, of course, is a magical place, but also a place with a lot of need. I think that the same concern that others have mentioned. How do you offer solutions to people when all elective surgeries have been halted in the public health sector? And when you're trying to provide a humanitarian surgery, when we're amidst this explosion of the pandemic, and we know there's going to be an explosion of needs. So I agree with Dr. Rossell. Being openly communicating with patients is very important. When we propose to ourselves to provide integral treatment care, so we're treating not only primary patients, but patients who need secondary surgery, corrective of previous surgeries. It's a wide range of patients. It's a very complicated logistical undertaking, much bigger than just a surgery. Dr. Thompson, Panama is a country, if you look at the economic indicators, they appear very well.
Unas brechas importantes y obviamente la necesidad también de.
But there are very wide gaps, and the needs for patients, of course, are very big. Yes, here in Panama, we have had that blessing, but also that curse. As you know, Ruben, you're also Panamanian. You know that the reality in Panama is not homogeneous. There's one Panama that's very rich, but there's also a Panama we also have marginalized populations who need a lot of help. Definitively here this all happened at the same time as a change of government. Our government that right now just had come to power when the pandemic started. And so that created a lot of confusion in the beginning. So there were some internal situations here that led to the management of the COVID emergency was there were a lot of stumbles, but now there's been some positive progress despite all of the initial stumbles. Even amid all of that, as an organization, we have attempted to provide the solutions, not only in the form of surgeries, but the idea that treatment of a patient, in the case of patients who have cleft lip or palate, they don't need just one surgery or two surgeries. Surgical treatment is just 1%, one small part of the care that they need. So the same time you're doing all this care, you're realizing all of the inequity. Yes, definitely. We are in permanent contact with that reality of inequity. Nevertheless, we have begun activities for a while now. We recently had a surgical activity, but always with that vision. We who work in medicine, we have to be able to prioritize. We can't delegate. All of our countries were in the middle of a health emergency. Some have been hit harder than others. But the huge amount of resources, or the limited amount of resources that we have in our health systems, are now all focused on attending to COVID patients, either primary that they're sick with COVID or other things that have been caused by COVID.
La doctora Lourdes Santiso.
I'd like to also welcome Dr. Lourdes Santiso. Sir, we pulled her out of the ER. We're so glad to have her here with us. Doctora Santiso, welcome. I would like to move on with you. I'd like to talk a little bit about the considerations you've had as a leader of your program. What have you had to think about when you're thinking about resuming surgeries?
Ay, disculpe, es que perdí el audio un minuto.
Sorry, I lost the audio a minute.
Solo para contarles que no, la verdad que nosotros como vemos quemaduras pediátricas, nosotros no.
So we see children's burns. We could never stop our work. We've had patients all year last year. We've had to continue to operate. The number of patients dropped about 30%, but we saw patients throughout the pandemic. We never stopped operating among the children who are our trauma and burn patients. We've had 14 patients who were COVID positive. 6 of them needed surgical care. We had to use special PPE. We had some donations from the Rotary Club. And right now, for a month, we've been doing elective surgeries. We have an external consult center where we can work. So here we are now working on our elective cases. Everybody has to have their tests ahead of time. And we also continue to have to work with some COVID positive patients. There are fewer children have COVID, but we do have cases. Of course, we're talking about a lot of cases that have had to cancel because of emergency cases. We see emergency cases, and we are a regional reference center, so we have to receive the cases that come. Sometimes we manage more minor cases. We have to take into account the socioeconomic condition and the educational level of the patient. Sometimes we can send them treatment home to do at home. So we've had to buy more phones to direct our rehab staff to send videos to the families about how to do their own rehab. We teach the parents how to do the therapy for their children, and we provide them with a phone if they need to call and if they have questions. But the most serious patients, we have had to check into the hospital. I'd like to ask our anesthesiologist colleagues, what specific considerations do they have to take into account to continue to work or to resume cases Dr. Gómez?
Pues Rubén, yo difiero un poco, como siempre, con algunas cosas, porque yo sí pienso, o sea, al principio todos estábamos llenos de pánico, pero yo creo
In the
que
beginning, we were all just in a panic. We were trying to get to know the enemy, but you quickly begin to learn, you educate yourself. All of our illnesses, the illnesses that our organizations address, they also have a moment of opportunity, the optimal moment to operate the patient. And it's important that your patient is in optimal health when you operate. Because of course the treatment in some of the phases of cleft lip treatment, it has to be done in the right moment for the patient. If we keep delaying their patient, they're going to have more long-term negative impacts. We try to operate very soon. So we had to educate ourselves on the use of the PPE. We had to get training as anesthesiologists about how to manage all type of patients amid COVID. We decided there are some things we can't defer. We have to operate when it's necessary. We are the ones who are called upon to care for these cases. The human resource, we are the most important. We have to be able to protect ourselves. And in the beginning, many of us, we started watching things that were on internet about the adequate use of protective equipment. That was the guarantee that we had to protect ourselves. Also to not risk our patients. Then we started to have access to the testing, the PCR tests and the others. And additional information started to come about how to manage our patients. So day-to-day things are evolving. Now, of course, we have the vaccine. So part of our responsibility is to be following the evolution. Doctor, you brought up something very important. Even if it's an elective surgery, elective for home, even if it's elective, they're very important needs, and there's opportune moments. I'd like to talk a little bit with our surgeons now about the considerations that they take into account when you begin to work with patients. In elective surgeries, there are some that are essential and there are some that are not. Some surgeries save lives or resolve disabilities such as the lip and palate surgeries. One thing we had to do was to properly adapt our clinical spaces. For us, having a mobile surgical unit, it completely separate from the public hospitals, that was an element that allowed us to move forward. But we weren't able to use our mobile spaces as intensely at the same volume. We had to reduce the rhythm of our surgical agendas. We had to adapt the spaces of put offices elsewhere to create wider space so we could spread out, so we didn't have so many people in a tight space. We had to have safe, healthy distances among patients in the pre-op and post-op space. We were able to work with a private space, and we were able to access PCR testing. So we were able to get 48-hour response to our tests. We also opened up our own shelter, our own home with different rooms. Used to be a university residence, but it had been closed. So we acquired that space and we adapted it so patients who live far away were able to come and isolate themselves in this residential space. We also activated telemedicine, remote consults, and we minimized the need for patients to have to travel. We also generated clinical consultations in the different communities to be able to evaluate patients in their communities and not have to have families traveling. Also, of course, it's an issue of we had to be able to access enough PPE. You're talking about an entire sequence of preparations to be able to do a surgery. Is your case similar, Dr. Rossell? In my case, we couldn't minimize other surgeries, ENT surgeries. They all are very exposed to COVID. We had to be very concerned about the safety of our professionals. A lot of studies that were published showed that there was differentiated risks for different health professionals. There's also issues of post-op infection with COVID. So we can't minimize or change the category of what is elective and what isn't. We need certain prescriptions or protocols to know how to address these situations. It's not the same in every context. Every country has a different reality. In some places, we don't have oxygen. We have a serious problem of oxygen. We don't have enough. So if we want to develop a protocol, we have to adapt it to the reality in each context. This is our reality. We've been able to attend care for more than 100 patients. We had one post-op COVID positive. We need to formalize and document these cases. And we need to understand that we need individual responses. Every one of our countries, the situation may vary. When can you start to operate again? When infection rates are high. It's hard to simplify things. It's not just a matter of logistics. It's very individual. This is really interesting. We're talking about the need of the patient. We're talking about everything that has to be done, even just to do a surgery. But then there are specific things you can do to have a sufficient margin of safety. But a lot of times, when we talk about protocols, we forget about the pre-op elements. How do we manage the patients? You who work in those fields, what strategies are you using to have patients sufficiently informed about opportunities and prepared? I think actually I agree with both of these postures. The moment comes when you have to say, we have to work. We know how to use take care of ourselves. But for example, for Operation Smile, we have certain standards. But we all had to, in one moment, stop and reevaluate and see what was safe. So we have developed a series of protocols to be able to resume, whether it's surgery or other type of integral care, or what other innovations do we need? We really started to innovate through telemedicine, online care, not only focused on the medical side, talking about how are we going to implement certain protocols, how are we going to adjust our protection measures, also how do we reach the patient, how do we talk to our patients. It's not even, whether it's telemedicine or a phone call to the patient to explain the situation to them. What about the patients who don't have access to internet and who come and who show up at our clinic, and that's the moment you have them there? We need to develop protocols that are understandable for those patients. We have to think not only about what we're doing actually at our clinic, but what kind of different educational materials can we develop for the patients who show up. And we have to take into account all the different categories of patients. There might be some families that the parents are educated and they just need a brochure. But other patients, their parents may not be literate. You may have to sit down with them and explain the basics of their illness. So we've had patients where we've called the patients to fill out a questionnaire before their appointment to find out if they have COVID. We found cases where patients had all the symptoms of COVID but didn't realize that they had COVID. So we, as an organization, even though our focus is on cleft lip, we had to explain to them, you have COVID, this is what it is. We had to develop standards and protocols of how to manage these patients in our clinics. And I agree with Dr. Rossell. We have to evaluate, each of us has to evaluate our own personal situation, the situation in our country. Nicaragua is a country, not everyone has access to a PCR test. Here, you can't just go to a private clinic and say, I want to get a COVID test. It's not possible in Nicaragua. But we are the only organization that has access to COVID tests. In order to be able to resume our surgery, our care, we have procured our own access to COVID tests for our patients. I think you're also talking about the opportunity that we as healthcare professionals can access different needs. Dr. Thompson, I know that you developed for Operation Smile certain strategies adapted to different countries. What are the critical critical aspects that you identified to provide options to countries amid all the information. What are the critical points? Yes, it was a very difficult task trying to summarize or to compile all of these realities that Dr. Percy mentioned. We're very aware that they're different realities. We had to turn to the scientific evidence to back up our decisions. And the availability of scientific evidence, based on that, we developed some guidelines. But those guidelines, they're alive. They're evolving. Adjusting as far as the scientific state, the latest research indicates. And we're trying to focus on personal protection, not only for the health personnel, but all the people who work with us, understanding that if we don't take care of ourselves, how are we going to care for our patients? That was one of the premises that we based our decisions on. We also tried to decide what were the best types of COVID tests to be able to detect, to early detect and to trace the COVID illness. That has been the foundation of our guidelines, and they are constantly, permanently being reviewed and updated. Right now, we are working on making decisions around international support, thinking about all the countries where we have a presence. We know we have to continue to move forward. As Dr. Paula mentioned, we have to learn to live with this new illness. But we have to base our decisions on what we have in our own backyards, on the evidence that we have. We also have to understand that we are not the only that everyone has the right to receive timely care. I want to lobby on behalf of my patients, but we have to understand that the healthcare systems in our countries, they're all seriously affected across the board. They're overwhelmed trying to address the needs, the health needs of the population. So we have to do our work within that reality. I think Dr. Santiso, the medical personnel numbers has dropped. We have lost medical professionals even among our surgical teams who have died. We would like to be able to do more. We would like to respond better, but we have to adapt our responses, prioritizing that first patients who need most urgent care, and then provide integral care to the other patients. You're talking to all, you're referring to all the variables that we have to take into account for decision making. Many of all of our panelists are in the middle of that. They have to take into account so many variables. Dr. Santiso, as time has gone by, what are some of the modifications that you have had to adopt to this new reality? What could you share with others, given that you've had to continue to operate despite all the difficulties? One of the things is that my hospital, it's a public hospital, and it is the largest hospital in the country, and it's the one that has had the most COVID patients in recent months. As Dr. Thompson said, it's very important to keep that in mind. Our worst months were July and August. At that time, we were overflowing with COVID patients. Now it has dropped a little. It increased a little around the new year. So this is something permanently changing, but the population in general, again, because it's a public hospital, we have to address all the other patients who come to our hospital as well. So we've been trying to open up more spaces for non-COVID patients, trying to designate certain spaces for COVID patients and other spaces for non-COVID. So we were able to designate 3 ORs. One is for COVID. That's an important change. We have to be constantly watching what the COVID situation is in our country. Right now, in my hospital, everybody's all excited about getting vaccinated.
Muy buen tema. En efecto, que queremos tomar. En los siguientes 10 minutos me gustaría abordar.
In the next 10 minutes, I'd like to talk about, to leave the last 20 minutes for conversation. A couple of you have brought up the topic of the vaccination and access to the same. And how have you used technological resources to be able to resolve patient needs? Let's talk a little bit about the vaccine. In my country, we were the last country in Central America to get the vaccine. We received a donation from Israel, but we had to halt it, but we finally got it. And we were able to vaccinate doctors and nurses first. And tomorrow, we will begin to receive vaccines from the COVAX system. It'll be the Oxford vaccine. It will be enough to vaccinate the workers at all the public hospitals, but we're a little behind. The pharmacies have been having a hard time accessing the vaccines. I'm sure in other countries as well. Thank you. The vaccine offers one way out, but when we see the projections about equitable access to the vaccine, some of our countries in Latin America, it might be 2022 or even 2023 before everyone is vaccinated.
Lo hablábamos en nuestra última conferencia. Yo en una de
We talked about it in our last conference.
Así como se comporta, ¿cómo se dice esto? La inequidad en salud.
We're seeing the inequity in access to health.
Dentro de las cuales nosotros estamos ahí de primeros. Creo que la vacunación ofrece un panorama muy similar.
the vaccine distribution is showing similar inequity, injustice in my country, in Peru, in Brazil. It's part of something we see in our culture. It's very Latin American, very cultural. We started our vaccination 3 weeks ago. First, those in the frontline health workers, still focusing on that sector, and those over 80. And then the next phase is those who have vulnerabilities. But it's going to take a long time to vaccinate. It's going to take a long time before we have herd immunity. In our geographical regions that are so difficult to reach, sometimes even our governments themselves don't understand our geography. It's a challenge in our region. And if we don't manage to overcome this pandemic, we have to have the majority of our population vaccinated. This isn't just South America. This is something we'll be seeing in Africa and Asia. It's going to take a long time.
Sí, bueno, yo creo que
Dr. Rossell. The first that we're receiving the effectiveness of the vaccine seems to be very positive. The problem is the inequality in its distribution. We know that the world works that way. It's not equitable. But I don't want to miss this opportunity to mention we can't lose our attention on we can't just think that the vaccine is going to solve the problem. This is an excellent opportunity to look at the huge limitations we have in our health systems. We need to reorganize our health systems. We need new infrastructure in our countries. They don't work well, our health systems. We can't be going 50, 70 years with the same surgical techniques. That's not how we should be taking care of our patients. This is a big opportunity to sit down and really talk and organize and talk about how we're going to care for our patients. We need to get all the medical professionals who are doing this work. We need to reflect.
De pacientes COVID y no COVID en un mismo lugar, hay que ver si es un ámbito público, si es un ámbito privado, y en base a eso poder organizar actividades que tengan.
We have to all, public and private, talk about how can we separate COVID and non-COVID patients. We're going to be living with this problem for a while. We need to be strong for what's coming. It's going to be difficult. If we don't solve this, solve the inequities now, it's going to get worse. I wanted to expand on that comment. I think we're thinking the same. I don't want to sound pessimistic, but we're not putting all our hopes in the vaccine. We have to see that vaccination process. Let's see if it's effective. And are we going to cut that vicious circle? I'm thinking that maybe from between now and the next year, if we're still not all vaccinated, I'm talking about throughout the world, we're going to be dogs chasing our tails. We're going to be in a spiral. We're going to have a situation with mutations. because of the characteristics of this virus. So this shot is going to be linked up with shots we're going to need next year. Like you said, we're going to have to start thinking about, we have to look and really look at our models of care, not only in the pathology of our patients, but in the whole healthcare system. The countries and nations have to understand that health is not a business, it is a right, and it is an obligation of the leaders of the governments to take care of the health of their populations. I'm not against, please don't think I'm against private initiative. Everything has its place. But the humans have the right to health care. It doesn't matter the person who walks a mud path or the person who flies in a jet plane. We have to look very closely at our health systems, our public health systems that are carrying the heaviest weight of patients in all of our countries. This is an interesting topic. Many of our organizations are investing more in emphasizing local initiatives, building capacity. But the topic of the different healthcare models, they all need to be focused on providing more care to the patients who don't have access, whether they're rural or urban patients, the ones who don't have access. I wanted to ask some of our other participants, how has technology facilitated the opening of activities amid COVID? What solutions has technology contributed? How have you been using technology in our region? Any of our panelists? I think that in my case, what we have been doing to guarantee access, opportunity for patients. We have adapted processes to the territory where you're working. I think we know how this virus behaves. The technology is helping us. Being able to access patients through cell phones is allowing us to reach very far. WhatsApp, for example, for our integral care programs has been fundamental, using WhatsApp. It's allowed us to reach patients, to inform them, to educate them. Something else that's been really helpful is creating alliances, bringing different efforts together. That has been very powerful, something that SmileTrain has taken advantage of. SmileTrain is providing us at MSI different technology. So cell phones have just been so key. It's really helped us to face this crisis. Any of our other panelists? We really, at one moment, I was speaking with Dr. Thompson. The pandemic was like a bell that reminded us of the basis of what we're doing. In terms of security, safety, protecting our own healthcare teams, it has helped us to channel our efforts. So we need to employ safety measures, not just around COVID, but there are a lot of illnesses that need our care, and we need to implement different protocols. So thinking about this, we've been thinking, today it's COVID, but in the future it could be something else. And we still have to be able to treat our patients. And not, some people don't even have access to WhatsApp or a cell phone. But many people do, regardless of how poor the country is. We're not going to reach 100% of the need of all the patients. But we did start to develop an online clinic as a pilot project with a psychologist and with our language therapist. We started to propose this type of alternative involving our healthcare personnel. Some people always say, oh, it's complicated because I have to see the patient. Sometimes the therapist will say, I have to touch the patient. They say we can't do it remotely. But we have always found it, but we have found solutions, and the online clinic is now established and does provide some alternative in pediatrics. But how would an dental pediatric dentist provide care? But we are looking at how they can use technology to take care of patients who can't come into the clinic or who are too remote. Unfortunately, our time is running out. I'd like to ask Dr. Santiso and Dr. Gómez their ideas about the use of technology, and then I'd like to open up so that people from the audience can participate. In our country, technology right now, we pulled a lot of things out of our sleeves, but a lot of those things are going to stay. It's provided a way to approach our patients, to reach them, to get them care. And now, of course, in only certain areas of medicine where it can be used. An anesthesiologist, a pediatrician, they have to see a patient up close. But there are other areas it's very useful. For an appointment to go over somebody's labs or images. Or just to cover some pending issues. Or for psychiatric support. But I think this remote care is something that we're gonna keep even after COVID. But I think there are other areas, personally, I'm very concerned about the legal responsibility of on doctors when they're using remote care. I just wanted to mention it really helped us. Some of these new technologies are here to stay. Now we do, it's very frequent that we do our Zoom meetings. We're seeing more use of it in postgraduate studies and students. The students had disappeared from our hospital for a year, and they were attending virtually. But now with our residents, we had to give them all their classes virtually. And they were there, even though they were doing shifts in the hospital and taking care of COVID patients. It's very important that we find ways to continue to provide education for our students. But the students, at least virtually, were able to continue to study the theoretical aspects. Now, fortunately, even the lowest income, almost everyone has a phone. We're able to do physiotherapy and some different treatment remotely. Thank you. Of course, the use of technology to continue to educate and form our health professionals is another big issue. There's some WhatsApp guidelines out there. There's a lot of positive uses. We need to continue to evolve our knowledge of all these technologies. I would like to suggest and request all of you who have been involved in developing protocols, we would like the G4 to be a platform to gather some of this knowledge. In our website, we have an area that we call SOTA Online on the G4 Alliance website. We would like to open a space where you could share your protocols, just among your colleagues. So that we can all have access to some of these ideas. I leave that as just a seed, just a thought. This might be a viable opportunity. We have a few more minutes. I'd like to open up the forum to anyone in the audience, if anyone would like to ask a question of our panelists. If you'd like to open up your microphone and ask a question, you're welcome to do that. Good evening. Excellent. From Bolivia. We are tired of hearing about COVID. We're all tired of it. But there's no set recipe. But there's something we can all. This was the year that time stopped. Time really stopped this year. And look at how much we've suffered. How many health professionals? They call us heroes, but we're not heroes. We have families. We have children. We're not martyrs. And we were held up as soldiers in a war, but we didn't have the basic elements to confront that war. But this is an unknown illness. And the treatment is changing and evolving. When we thought we had the answers, then they changed the questions. So it's really important that we all look at all of this. In my experience in reconstructive surgery, so one thing we did see is there were fewer burns, fewer reconstructive surgeries needed because of accidents during the pandemic. And we also discovered that many patients turned out to be positive with COVID, but were asymptomatic. And I would like to ask a question of Tatiana. Are you going to be, if the surgery that I have to do is in the mouth of the patient, I'm face to face with the patient. The surgeon and the helper, they're right there in the face. They're directly exposed. Can you assure me that there's no aerosols? No, we can't guarantee that there won't be. We all have to take care of ourselves and we have to take care of the patients and take care of ourselves. I'm very excited about what we heard from our friend, Dr. Sierra, the way he created a whole infrastructure. We have focused on surgery because we had COVID and non-COVID patients all in the same hospital, all in the same place. These are very beautiful topics. Congratulations to Rubén and all the panelists. Thank you. Dr. Sierra was giving us a tour of his mobile unit. Any other questions from our audience? Remember that your microphones are off, so if you have a question, you can turn your microphone on. Good afternoon. Good afternoon, everyone. I'm an anesthesiologist. I'm in Peru. It's very interesting, everything you've talked about. We've talked about whether the patients have COVID or not COVID, but also among us, the healthcare professionals, we can get sick. And there's also the risk that my colleague has COVID. And someday I had a coffee with him and I got sick. We can't lose. We don't have to protect us just from the patients, but we can catch COVID from anywhere, from anyone. I think we all agree. I would like to intervene. Those of you who've been listening to this conversation, to make that observation, to leave a positive message. I hope you haven't perceived everything negative of what I've said. I think that this crisis, this health crisis, has opened up an opportunity to us to develop strategies like we're doing here, like each of you is doing in your country, throughout Latin America. We're very creative in Latin America. We find ways to resolve problems, sometimes in folkloric ways. I think in my particular case, in this year, during the pandemic, we started to reinforce our own team. And I've been very, very proud and very pleased to see that how the countries in our region, in the Central American region where I work, I have seen how countries of this region have developed their own capacities, their local capacities, their own work systems. Maybe they're modest in terms of the number of patients that they treat. Nevertheless, they have taken important steps to be self-sustaining. I think when Dr. Rossell mentioned the numbers of patients, I think the care provided in our countries, among our organizations, we're not going to wait for a mission team to come in 3 months to operate 80 patients. We can't be. we have to be knocking on the doors of our local health institutions. There's always interest to collaborate, to help the populations who are in need. I want to take advantage of this opportunity to congratulate the directors of the organizations in our countries, excellent work that they're doing, and how they're applying the health protection measures that have been developed very, very carefully to protect our patients and our staffs and the volunteers. Thank you, Dr. Thompson. We have a question from Silvia. I was listening. I agree with much of what was said, but I wanted to mention is that we want to share knowledge. I heard that many are doing tests of cleft lip and palate patients. But if you're doing a COVID test and then you're going to have the results 3 days later, what if they get sick in those? What if they catch COVID in those 3 days? But we need to keep following the developing knowledge and science and keep learning more about the protection measures. We can't assume that everyone knows how to protect themselves. Even if somebody is a doctor, they might not be up to date on the latest science. Thank you, Silvia. We are running out of time. I would like to ask each of our panelists if you want to share some closing words, maybe some closing thoughts. I have seen in the chat, there are some links for more information. You can also go to the G4 Alliance website to share more information. Dr. Sierra, would you like to begin some closing words? Thank you, Ruben. So, in our experience, we have been working 2.5 months of surgeries. We've operated more than or close to 100 patients in these 2.5 months. We have to, it's important to try to find COVID-free spaces. Generate some spaces, create some spaces that you can keep free of COVID. And then define all the different spaces of the steps of care and develop the best way to address each of those spaces and steps of care while keeping them safe. And it's really important to develop alliances with different organizations. See if somebody can have a space where you can isolate patients before surgery. See if there's somebody who can provide transport that's safe, to avoid that patients are traveling in public transportation with others. Develop strategic alliances. And that will also help alleviate the financial stress on one sole organization. In our case, we haven't had any COVID cases. If this can be done in Oaxaca, I think it can be done elsewhere, and we're very happy to continue to share our strategies. Thank you.
Gracias por estar con nosotros. Voy a pedirles, por como los veo en la pantalla, doctora Santiso, unas últimas palabras para nuestra audiencia.
Dr. Santiso, do you have some final words? First of all, I'd like to congratulate everyone who work in foundations and different organizations, at least in my country. A big part of what the healthcare system has not been able to do, even though it's their responsibility, it's been through the support of all the organizations that work in our country in different pathology in different areas. We have been able to get a lot of help. So I want to congratulate these organizations for their efforts. I belong to one of them, but I work in the public sector, but I've worked for many years in association with Physicians for Peace, and they've supported us a lot. I think they're an essential part of our system, of our health system, at least in Latin America, and I want to congratulate them. The other thing I'd like to say is I'd like to follow up on Ruben. Let's all send in our protocols, our strategies. Maybe we could compile kind of G4 member document of our different protocols. And talking even just about the different creative strategies we've developed this year. It is very nice to be able to connect with each other as colleagues. Dr. Gómez, did you want to add something? I'd like to share the message that what I have learned in this pandemic, working on the front line, and also while doing some elective and non-elective surgeries, we can't forget that we are the human resources.
Como les dije ahorita, esto se va a quedar con nosotros. Entonces, es nuestra obligación buscar estrategias.
Our obligation as healthcare workers, we have obligations to implement the right to health of our patients. We have to protect them. Sometimes we forget in certain pathologies or illnesses, we can't harm our patients more. So we have to always be using our protection protocols. But without us, we can't guarantee care. But the solutions are going to come from us. We're the ones that will help them manage their illnesses.
Muchísimas gracias, doctora. Muy bien dicho.
Thank you, Dr. Gómez. Dr. Rossell, I want to thank you for the invitation. Thank you, all the panelists. To close, I wanted to share a message with all of those who are present. If you've been looking for solutions, if you have had expectations of solutions, but I want to point out a few things. But there's not one prescription for everyone. As Dr. Thompson said, we have to continue to be creative. We have to adapt and find solutions to problems. We have to find ways to operate in the safest way. But we have to look at the conditions in our city and in our country. We can't do surgeries if there are no ICU beds. Maybe we can't massify right now. Maybe we can't do a large number of surgeries in 1 week if there aren't enough ICU beds available. So we have to look at our local conditions. And what about, is our access to diagnostics limited? We have to have all of these working conditions available. And I also want to highlight all of these experiences that we're having. We should document them and look at them objectively, look at what we're doing. And if we're if we're having successful experiences that are helping to serve our patients, share those experiences. This can contribute to the science. We can pull out some lessons. I think this is really important. We have a lot of experience. We were able, in our experience, we developed a specific protocol that allowed us to operate 100 patients. We need to share that. And I think it's an example for everyone. It's really interesting what you're saying. There's a lot of opportunity here to share our experiences, our lessons, our opportunities. We could develop a consortium to evaluate our strategies. Dr. Thompson? I think Dr. Rossell has been very clear in his opinion, which I share. We have suffered an impact, and we're coming out of the hospital, you could say. We are learning to walk again. We have to start first, walk carefully, collect our strength again. Maybe that's like a simple metaphor, but what I'm trying to say is, despite the fact that maybe we're not being super effective, but we're moving forward. We're taking steps, even if they're slow. We have to be safe, and we have to develop self-sustaining systems and reinforce our healthcare systems in our countries. I think we need to make firm steps and remember that everything that we do has to be for the good of our patients. We are the ones who have been called to find solutions based on scientific evidence, supporting ourselves in biosecurity measures. Thank you, Dr. Thompson. Licenciada Morales, we can close with you. I'd like to thank you for this opportunity. This was a nice experience, a wonderful audience. We've all learned from each other, different perspectives. I know there are a lot of people from different professions.
Recordemos que la seguridad es primero, no solo la seguridad del paciente.
Let's all remember that safety is first, not only the safety of the patient, but us as well. As the medical team, we need to reinforce our teams, our local teams.
No continuar operando masivamente en grandes jornadas.
Maybe we don't need to be operating in big, massive campaigns with high volumes, but in little by little. But that's only possible when we have local, reinforced, strong teams.
A ciertas fundaciones y recordarles que son los voluntarios, son las personas que trabajan con nosotros quienes
remember that there are local volunteers who form our organization. Every one of our volunteers, it makes an important contribution to our organizations. It's these people who are doing the work locally, who are volunteering. We all depend on them doing their work. And also remember the different members of our health team. Some are comfortable to be working, and others are very reluctant and very concerned about their safety.
es Smile Train, para otros la bandera es Operación Sonrisa.
And maybe we all have different flags. Some are Operation Smile or Smile Train or another organization.
Sí, pero yo lo hago, si yo lo puedo hacer en el privado, ¿por qué no lo voy a hacer en la fundación? Y al final es a veces lo mismo, es ayudar, nada más que en unos me pagan y en otros no. Y es un tema bien controversial que de pronto existe dentro de los voluntarios, pero que creo que al final del día no soy yo, no es el doctor Thompson como de forma personal, sino somos la bandera de una organización.
Sometimes when we are working, we have to remember that we are speaking and representing our organizations. And we have to think of the other members of our organizations. The flag that each of us has to wave is the flag of the patient. Today is a demonstration of that. If we can all remember that gives us hope. And we've been together almost 2 hours. Please remember that. These are opportunities to really enjoy the fact that we have friends who are trying to develop solutions to confront this challenge that we're all facing day to day. I'd like to thank you to all of our panelists. We are so lucky to have you. Thank you for each of you for coming back. The time, we've been here almost 2 hours together. And I'd like to thank everyone who joined us today. We have more than 100 people even now, even though we went over time. Maybe we can continue this dialogue. We started out with personal experiences. We've talked about patients. We've talked about innovation, creativity, vaccines, strengthening our health systems. We've talked about many topics. So there's nothing left but to say thank you. We continue. We are an alliance. Thank you. And we invite each of you, all of the organizations and all the individuals here, to continue to invite others to join us in these conversations. Thank you to the organizing team. Thank you, Natalie and Dan from the G4 Secretariat. Have a wonderful evening, each of you. Our respect, our affection for each of you, and to all of your families. Good night, everyone. Thank you, thank you, thank you. Gracias, thank you.
Chao, Percy.
Gracias, buenas noches.
Gracias.
Good night, everybody.
Gracias, Rubén. Gracias.
Gracias.
Gracias, Rubén. Gracias, Rubén. Gracias,